thinking about working and overtime working, etc. So where we are week 10. This is just the week where I'm going to do a HESI review. What I'm going to do is take a PowerPoint. I made it. It's completely from your Saunders PN and Clicks book. I cut and paste, put it on there with all the HESI hints. It's in one place, and I got rid of all the extraneous stuff there. So it is 90 some odd slides. If you look at it, it's repetition that goes on through the slide. And I think that have told me that this PowerPoint, the Saunders, is spot on for the HESI. All the HESI hints and whatnot that you see there is things that you're going to see on the HESI. So remember with the HESI, take your time. Please make sure you read the questions. And then, look at the key things in it. Do I know what this diagnosis is? Do I know what this means? And you're going to be just fine, all right? It's going to, because this class has done extremely well. Most of you have just got to pass a HESI. Some of you need a little bit more then, but it's really been an amazing class. So thank you for all the hard work you've put in, because it's extremely evident. I haven't had to be behind you getting homeworks. I've told you when maybe a name was missing or wasn't right format. That's okay. That's a normal thing. But overall, an amazing class. So thank you for what you do too. So Anika, when you have a chance, turn on the camera. I know you're just getting in. So let's go ahead.
She said she went to the bathroom.
You just got home, so I'm sure she's changing and getting comfortable, and I'm sure that just getting home means that, she hasn't gone all day long for many people, right? I remember one Christmas working a 12-hour shift, came home, and I hadn't gone to the bathroom all day long in 13 hours. That's how busy that day was. So as a nurse, it happens. Anyway, but nursing's the best thing that's ever happened to me. I've always enjoyed it, and I've learned something every day. And for me, that was everything, learning something every day. So here we go. This is the Saunders NCLEX book that you have. It's part of your NCLEX questions. This is the pediatric section. So I'm going to go over those key things that you might see pop up on you. So of course, let's go back to growth and development, the first year of life. Isn't that amazing? You go from 7 pounds, can't lift a head, to 21 pounds, and you're walking and you're babbling and talking words. Quite amazing that happens. This is the most growth of any time in any part of your, being a person. So weight doubles at 6 months, triples at 12 months. When we talk about the growth of these children, we know that their birth length increases 50% by 12 months. Actually, what they do is every month for the first 6 months, 1 inch every month, 6 inches in just 6 months. So that's part of that 50% in 12 months. Remember that fontanelle in the back? It's closed really quick by 2 months. This one here, the anterior, is going to be open till 12 months, 15 months. And if it closes earlier or it's open later, that's something we as nurses should look at and tell our physician. They should be able to smile. They turn their heads when they hear sounds. And then they're moral, that startle, that, you touch the bed and it startles them. The hands and the feet come up. Moral or startle. It disappears about 4 months. I mean, you can still startle a child, but it's not as tender and as touchy as it is when they're earlier. Head control by 4 months, even say 3 months. They're able to lift their head up and be able to move it around. They should be able to completely turn over. That means abdomen to belly, 5 months. The back to their belly by 6 months. So completely turning over by 6 months. That's a safety problem right there, because now they can move. And then peekaboo. I love playing peekaboo. I was just doing that earlier today at a doctor's office with this little boy. Peekaboo. and he was giggling. So I had to share that with you. So then we go to the grasp. The grasp is a big thing. Remember, we start out with that reflex, mom puts her hand out, the kid grabs it, reflex grabs it. And then all of a sudden they're into, oh, I want that rattle and takes it. And then it starts at 7 months, rattles in this hand. They've shaked it. Ooh, I like that, right? And they put it in the other hand. That's about 7 months. Stranger anxiety. This is when other people want your kid and they don't want, and they cry and they turn around and crawl back on you. That's about 7 to 9 months. By 8 months, they should be able to sit up unsupported. Now, they're going to be sitting up earlier, but you have them propped up with pillows and stuff, right? 8 months, all by themselves, sitting there. They're crawling by 10 months. And then not only do they take that, voluntary grasp, they put it into this little pincer. And now they're taking little Cheerios or those little puff things, and they could put it in their mouth about 10 to 12 months. And that's the normal for them. Bye bye, 10 months. And then walking. Now, children start working with mom holding hands first, or we know they're walking, holding on to things, and that's at 10 months. By 12 months, they should be attempting to take a step by themselves. It doesn't mean they're going to. As I've said, my children and even my grandson that I referred to a lot, he never walked. He ran at 15 months. He never took one step. He took 15 steps down the hallway. And that was normal because everything else was normal. He just walked slower. But all of them were actually pretty pudgy babies. So they didn't want to hold their weight, I think. By one, mama, dad, milk. Simple words. Or it might be Nana. I was having my grandson saying Nana. So those are normal. And then, of course, remember, the whole world is explored through the mouth. So they move it, put it in their mouth. And that's how they stress, release. The world's explored all orally. So this is one of your discussion questions. So I like that we do that one. It's all about separation anxiety. Remember, he screams when you leave. Then they sit there and they regress, suck their thumb, wet their bed. And then they're like, okay, whatever. And when mom and dad comes, they don't want them. They're going to go back to that nurse who has been there, because how do we take care of separation anxiety as a nurse? Well, if we're there 3 days in a row, this child, if the parent's not there, we would want that same person, nursing assistant, LPN, RN, whoever it is, same person every day. That consistency gives them a little bit of security and comfort. Okay, more HESI hints. When does the birth length double? 4 years. Again, sitting unsupported, we know that, 8 months. 50% of their adult height is by 2 years old. So if you look at a 2-year-old, we know that that's half of what they're going to be as an adult. So we can see how tall they might be. When do they throw a ball? So now we've been the fine, the pincer, all of that. Now we're throwing things. By 18 months, and my grandson, the first time he did it, threw a ball. Thank goodness it didn't hit me. It went right past my head and bounced off the wall. It was a tennis ball. And if he would have hit me, that would have hurt. And that's normal. 18 months, wham. And it doesn't matter if they do it with the hand that they're going to end up writing with or the other one. They use both hands now. 2 to 3 word sentences, 2 years old. I don't want to go. I don't want to, I'm going to do. I want to eat. Little things, they're going to be saying that. Scissors, they should be able to use them by 4 years. So preschool, that's when they give them the little rounded, child-proof scissors, and so that they can use it to cut paper with it. Tying their shoes should be about 5 years. That's actually delayed today. And not, use what the book says, but think about it. Kids have all of these Velcro strap sneakers now and shoes. They don't have ties, do they, until they're older. So many kids aren't till they're older do their shoes be able to tie them. Which behavior indicates that thyroid hormone therapy for a 4-month-old is effective? Well, let's pull this back and look at that question more. If you're born without enough thyroid hormone, your cognitive development will be delayed. That's what this question is asking. So if they are 4 months old, they should have good head control. That's telling you cognitively they know and they can hold their head up. If they said 6 months old with the hormone works, they're turning over. So they're meeting the milestones, okay? Remember, girls grow up quicker than boys, usually 10 for girls, 12 for boys. Temper tantrums and toddlers. Me, mine, I do, and it's absolutely normal. It's just part of who they are. It's the toddler. Be aware that adolescence is a time when the child forms their identity. Who am I? What am I going to be? Do I like girls? Do I like boys? Am I going to be a doctor? Am I going to be a teacher? And mom, you're not going to tell me what to do anymore. So that rebellion starts. They want to be more of the adult and, do in their time frames, not in what mom or dad would say. So Erickson, school age. What do we know about Erickson school age? Industry versus inferiority. Industry, it's that house. It's what I do, what I've built, what I can do well. And I want to show everybody that I can do it. Makes me feel good, right? Now, we also know part of the cognitive development, etc., is peers now. Same-sex peers become very important. So PN should know children's concepts of bodily image. So we know that when infants are born, they don't remember a lot of things, but after 6 months, they remember pain. They're going to remember that immunization, 2, 4, 6 months. They're going to remember, oh, there's the nurse. Oops, I'm going to have pain. That's at 6 months. Toddlers don't like anything that cuts into them, squeezes on them, anything. Preschooler goes to the point where it's body mutilation, as in, cut, I'm going to bleed out and I'm going to die. That's why Band-Aids are the big important thing at preschooler. School-age children want to control themselves, be able to do everything, but they're not quite there yet. And then adolescents are all about body image. Who am I? What do I look like? Do I like my hair short? Do I like it long? Do I like it curly, straight, whatever? Acne bothers me. Am I too heavy? Am I too fat? All of that, body image. Accidents are always, remember, motor vehicles are always your accident, major cause of death. And we know it has to do with teaching them accident prevention, safety, right? Teaching them for instance, if they get a driver's license, how to use that well, or as in they're in sports, making sure that they got the proper equipment. Adolescents tend to have no filter. They tend to go straight ahead and they get hurt because they don't put on the safety helmet. They don't stretch. They don't warm up, or they forget to put the seatbelt on in the car. All of those things. Pain scales. Remember, there's 3 that I've seen on all of your exams, and that will be FLAC, which is 0 to toddler, and all nonverbal children. It doesn't matter what age. And then there's faces. At age 3, preschooler, they can now point to a picture, those faces from 0 to 10, and they can point exactly. And I love it because they tell you exactly what they're feeling. They don't exaggerate more than what they are. And then we go up to the numeric, and they say 9 years and older from 0 to 10. I've had younger kids do it, but this is what the book says. From 0 to 10, how much pain do you have? Remember, you need to document it. Remember, it needs to be done every shift. And remember, you need to evaluate the pain after you medicate them. Okay. So remember, pain is not just giving them morphine for sickle cell or giving them ibuprofen for JIA. It's other stuff too, that putting heat, putting cool, whichever one they like. I mean, I have rheumatoid arthritis. I want to be in a cold ice bath. Do not put me in heat. It makes me worse. Or maybe I need repositioning. Children, distraction, distraction. It's all. And remember always, anything you do for a child must be based on their developmental level. We know infants love their pacifier. Remember, self-soothing, and they just like that nice, calm holding and rocking, and you can feel them be comfort. Toddlers and preschooler are all about distraction. Give them something to do that they want to do. Show them a neat truck to a little toddler boy, and they want to play with that truck. And preschoolers, maybe it's an iPad, and they want to play a game on it, bubble blown, whatever it is. Toddlers, preschool love distraction. So before you give medicine, always in children, always look at the dose. Is it a correct dose? Is it safe? Yes, we always look at the narcotics. It's just part of, we need, double witness. But, you think acetaminophen can be benign, but remember, you can get, your liver toxic, hepatotoxicity from too much Tylenol. So always check your dosages. And I always have, because I do have seen mistakes about it. Remember, with opioids, you're going to make sure that you are going to double check the order, of course, double check the dose and vital signs before and after. One of the things about children is, we have something called a patient controlled analgesic pump. This is something we see in the adult world a lot. We don't see it a lot in children because usually there's nothing that severe that they need to be pushing their own button along. I think maybe in the cardiac ICU would be a great thing to use because their chest has been, busted open with surgery. But as long as the child understands what it is and what it's for, they're actually safe with them because they can't push it too much. Because if they push it, they're going to fall asleep and they can't push it again. One of the things kids don't like is to say that they're in pain. And the reason is they always equate pain to getting stuck with a needle, always. And remember, my dissertation and my doctorate program is school age children attitude and behavior towards injections. And what they think is you're going to get an injection. They're afraid of them for whatever reason. And they're going to say, I don't have pain. So remember, if we can give it orally, if we can give it through the IV is actually the best. They don't even have to swallow anything, or maybe even topically. Whatever works the best with the least intrusive method on children will actually make sure that they tell you if they're in pain or not. They might have to deep breathe and cough, prevent atelectasis, ambulate, to keep that blood flowing around, preventing blood clots and DVTs, etc. So communicable disease is rubeola. Rubeola is measles, and we know there's a vaccination. It's 2 doses, 12 to 15 months and 4 to 6 years. I've actually not seen measles come around. Now, chickenpox, varicella zoster. One of the things, this is a live vaccine. So remember, anybody who is on steroids or is immunosuppressed, you have to be careful with giving these to them, okay? Varicella is something that is droplet and it's big chunks out in the air, and that they are actually contagious before they even break out with a rash. When do they stop being contagious? When can they go back to school? And that's when your scabs are all dried up and that they are, scabbed over. If they're dry, they're okay. So varicella is at 1 year and at 4 to 6 years. Rubeola. The big thing about German measles, it's the problem with contact with a pregnant mother. We don't want a German measles to be around a pregnant mother because they can contaminate the mother, that unborn sibling or unborn baby. Okay, that's the biggest thing about rubeola. So nursing care plans for communicable disease, you always isolate, put a mask on them, put a mask on you, get them into a reverse airflow if that's what they need. Okay. Remember, never aspirin. Non-aspirin, acetaminophen, we start with, because remember, there's Rey syndrome, and children who've given aspirin who develop Rey syndrome are extremely ill. These occurrences with these outbreaks like rubeola and measles, German measles, which are protected with vaccines, are all should be reported to the health department. They can locate where's it coming from. Maybe we can get to that school or that area where it's coming from and find out and make sure everybody else gets immunized, right? Those rashes that come up, especially chickenpox that itch, make sure you cut the nails, put mittens on if you have to, and those Aveeno, those soothing baths can really help. And diphenhydramine can be used for itching. I'm going to warn you about putting lotion with diphenhydramine or Benadryl lotion on them. You can overdose with just Benadryl lotion. Okay, I saw one kid in a catatonic state from Benadryl. So again, remember, smaller amounts are better. And of course, with all of that, wash your hands. Now, nutrition, iron deficient anemia. Why do you think the toddlers are all about iron deficient anemia? They're let to eat normal foods now, right? They don't like all their foods and they become picky eaters. And we call them almost a physiologic anorexic because they're eating tiny little pieces of food. And the food they want is chicken nuggets, macaroni and cheese, and they don't want any of their vegetables, right? And that's your green leafy, and that's why iron deficiency is your toddlers. Also, think about adolescent females. These are adolescents, body image, not eating properly, eating on the go. I'm too heavy. I'm too this. They don't eat, right? They're not getting nutrition. And again, iron deficient anemia. And of course, any female childbearing, we need to watch really closely. The vitamins most often consumed in less than appropriate amounts. Vitamin A, C, B6, and B12. So these are things that we should look at and incorporate into diets to help them have those for good body growth. Adolescents, remember they're growing a lot in that beginning of adolescence, right? That 25% of their whole life. Well, remember, they need extra nutrition. Just like that first year of life, an infant, they eat, and we give them a lot of food. Adolescents need it too, but do they do that? Not all the time. Always with anything with a diet problem, too skinny, too fat, whatever your word for it is, 24-hour recall and a food diary, always something that's going to be asked for. And that's going to help you key in on what is this child missing in it. And it could be from a toddler to an adolescent, doesn't matter. What have they eaten in the last whatever? And then also have them record how many types of the food groups do they eat per day, per week. Now, diarrhea. Diarrhea excretes a lot of alkaline. All of your digestive proteins are alkaline. So diarrhea, you're losing it. What do you have left? Acidosis. So complications, number one, and the big one is dehydration. Dehydration can kill children. So really important that we, you know, identify it quickly. And that is elevated heart rate, decreased blood pressure, changes in mental status, mottled skin, prolonged capillary refill, not urinating. All of these things really are those complications of diarrhea. How do we replace diarrhea, the dehydration? Well, it could be IV or PO, depending on the child, right? Here's some other things with dehydration: poor skin turgor, tenting. In infants, a child with dehydration due to whatever cause, you're going to have a depressed fontanelle and they're going to cry and there's no tears coming out. I think it's the saddest thing to see a baby crying and there's no tears, but you can see that little quivering little chin. You know that they're crying. Remember, when we give fluids for dehydration, should never ever be given potassium until that child is urinating. Very important. We could kill kidneys if we gave it before they were urinating. Potassium levels could be too high, okay? And urinary output for infants and children, 1 to 2 mLs per kilo per hour. You know, adults is 30 mLs an hour across the board, right? Well, in children, it's 1 to 2 milliliters per kilogram. So diarrhea, what are we going to do? Well, how do we know this child's getting better? Well, we're going to see the fontanelle get better, heart rate go down, blood pressure go up. We're going to see that their intake is going to be less than their output because they have to gain it. Also, could be weight gain if they're in the hospital. All of these things are telling you fluid is working. And we know that because they've lost all of this alkaline in their stool, we're always going to give fluids. If orally, they're going to have oral electrolytes, right? Rehydrate with it. And when we can, we'll put the potassium or whatever they need in the IV fluids. We'll always check stools for the pH. Is it alkaline, acidic, right? Most of the time it's alkaline. Is there glucose in there and blood, just to be sure? And urine specific gravity. Why do we check specific gravity? It can show if you're dehydrated. The number's elevated, 1.10, 0.20, that's normal. But what about one higher than that? Well, it's telling you the urine's concentrated, you're probably dehydrated. And always, isolation universal, wash hands, wear gloves. Now, child abuse. You think child abuse doesn't happen, but I've seen it. And I've seen some really nasty things. And remember, um, our job as healthcare professionals is, if we have a suspicion of it, we need to tell somebody above us, our charge nurse, our charge doctor, somebody, to say, this just doesn't look right. So injuries are not congruent with the child's developmental age or the skills. That means what they say that kid did, and it's impossible. They couldn't have done that. So injuries would have been somewhere else. And the injuries and what they say, they're just not jiving. They don't look good. What if they have bruises that are yellow and green and purple? And we know that stays old now, right? So we know that there's something going on. And then those various stage of bruises. And then, of course, if we can see outlines of belts or cords or whatever, cigarettes, sitting them in their butt in hot water. I've seen these things. Whiplash, that shake and bake injuries. How about hair being pulled out? That shouldn't be done. And then fractures in various stages of healing. I saw one 3-month-old baby who was a twin, had a fractured skull, had a fractured right humerus, had a fractured right femur, and had fractured ribs of all different stages of healing. Yes, a 3-month-old. They pulled in the twin, and I caught it in a triage area. I still cry about it. They called in the brother 6 hours later. I want you to know today, and there was a 2-year-old brother who also had a fractured femur walking on it. these children today are safe, okay? And that's the bottom line. Keep the children safe because it is real. I've seen withholding nutrition. I've seen them, with the beatings. I've seen the sexual, and I've seen this, kid with a fractured skull. So these things do happen. They are a reality. Do not look at the person who brings that child in like you did it because usually it's not. Okay. Remember, there is some what we call failure to thrive. This is when they're not gaining weight. Remember, it's not always about that they're vomiting a little bit, not gaining weight, but because it's been going on so long, they should have already received care. So if they're still not gaining weight and they haven't gone to medical care, the GI doctor, whatever, that actually is abuse. They're not getting what they want. And then, of course, looking at their clothes. But kids are always dirty. They always have dirty fingernails or always been out in the yard, but there's an extent of it. So be careful with that. And see this, PNs are legally required to report all cases of suspected child abuse to the appropriate local and state agency. If you were in a hospital setting, you would be telling the charge nurse. They would be calling in DCF, calling the police, and all of those things. Yes, they are. And our job, again, keep our kids safe. Now, kids poison themselves, right? They eat everything. They eat everything from rat poisoning to mom's grandma's heart pills to oh, they love getting in their vitamins. Oh, those are the best. Or their little chewy Motrin or acetaminophen pills. They love those things. Remember, we do not make kids vomit anymore. Epicac used to be the waylaid standard. You know why we don't do that anymore? Because they aspirate it, get in their lungs, and now we have aspiration pneumonia of this chemical and another burnt esophagus trying to get it up. So we do not induce it anyway. What would we tell our parents? You should have poison control number posted, and it should be in your phone as one of those favorites ready to dial. Now, respiratory distress. Respiratory distress in children. Well, it's adults, it's children, it's anybody, okay? But where it becomes different in children, especially infants, flaring nostrils and that grunting, that at every breath. I tell you, if you have a small child who's grunting and nasal flaring, retracting, head bobbing, that child is about to code on you. Get help in that room now. Okay. I mean, yes, you're going to see increased heart rate, pulse rate, restless, all those other things. That is a typical restless, but those other ones are your infants. Let me plug in my battery. Hold on. I forgot I took my battery cable out. All right. So, what is your goal? What do you want to do for this child? Do you have a child who is getting increasing in respiratory distress? And let's say that kid huffing and puffing and is wheezing and struggling. Well, what are we going to do? Well, we're going to give them something, especially in those acute attacks like asthma. We want that rescue, that rapid acting bronchodilator, that albuterol, Preventol. Those are two different names of the same thing. And they'll be getting steroids depending on the severity and how bad they're not breathing well. It's steroids orally or intravenously. Of course, always keep a kid hydrated. Even those younger kids, they need fluids and quickly. So either IV fluids or oral. And if we get blood gases, what are signs of respiratory acidosis? Low pH and elevated CO2. Those are two key things. So 7.16 with a 62 CO2, that is going to be respiratory acidosis. If they need oxygen, remember O2 sats of 90 are okay. But if it's 86, they need a little bit of oxygen to help them, okay? Then they're going to get other different things that'll be given is. So sometimes they do levobuterol, which is, doesn't affect your heart as much. And we're going to be giving those things morning and night. With adults, they have things called Symbicort, Advair, Brio, and they do those twice a day, morning and night. And they're that preventative one. Well, it's something called budesonide or Pulmicort in infants. And that child who's been diagnosed as asthmatic, it's probably going to help them have asthma attacks. So morning and night, preventative. Cystic fibrosis, what is it? It's two places in the body. It's the lungs. The lungs are full of mucus. So we got to work on that a lot, right? The second part is the small intestines, an obstruction of enzymes that are there for digestion of nutrition. So there's pancreatic insufficiency. So what would you see? Well, a kid with cystic fibrosis is oozing salt in their skin, in their sweat. So this would be a child the mother would say, tastes salty. This would be one that we're going to do that sweat test to determine that it is cystic fibrosis, okay? Now, because they're not absorbing all their foods, these children need really good nutrition. This is the child you're going to give as much salt as they want because they lose it that quick. And they're going to need high carbohydrates, high protein, and they don't tolerate fats that well. This is going to be that steatorrhea, smelly, frothy stool if we find it later on in life. And remember, if children, especially infants, are not getting nutrition, cognitively, they're going to be behind. Growth and development, they're going to be small. So we're going to take care of their lungs. We're going to prevent infections. We're going to be giving them that medication, that pancreatic enzymes before meals, okay? And you could put a little applesauce, rice, or something and give it before meals to infants. Now, they lose fat. Remember I told you they don't like fat. And they're just get rid of it. So we got to be careful of those fat vitamins, A, D, E, and K. Now, if their lungs are going, we're going to give them albuterol treatments. They're going to get CPT, or they're getting antibiotics in the aerosols, tobramycin, gentamicin. Not common to put in an aerosol, and making sure that we keep that good and loose and keep it from being infected. And like I said, high calorie, high protein, and actually they want a little bit lower fat because they don't take and they don't absorb it. And always these kids, just when we're doing respiratory treatments, keep them distracted. So more oxygen, OxyHood, that clear little plastic hood for infants, the easiest, nicest, and we can really monitor exactly how much oxygen is in there. Those little nasal cannulas, they tickle. They don't really like them, but a little bit of oxygen, and I'm talking a quarter of a liter, we could put it down to on these children, and that can help. Tents. This is something we didn't talk a lot about. This plastic that goes over the head and the air and moisture blows in and the child's inside. Now, many kids don't like to be in there alone. So what would you do? Have mom go in there with them, right? Or have that big air coming out and have them sitting on mom's lap, getting that moisture and getting that in them because they need that for their lungs, okay? Couple different, be creative. How would you get a child that's under a tent to stay there, or how would you get them what they need? So it's either mom's lap or have mom or dad sleep with them. I would make a bed for them. Get in there, take care of the kid. Kids getting what they need, and also they're getting moist. So always keeping them dry, changing their t-shirt. I usually will tell them, you're going to be changing jammies forever. Let's just put one of our little gowns on and change it like every 2 hours, and literally every 2 hours it needs it. Pulse ox, always remember, they say we want above 90. That's what your book says. Okay. So they always say, though, normal children that are above that, if they're starting to get lower, set your sats at 95 as your load, as your one that the alarm will go off for. And again, looking at blood gases when we need them. Epiglottitis, what is it? The swelling of the epiglottis covering the trachea, and you can't breathe. Air can't go in. There's this big thing on top, air can't go in. It is life-threatening. It is caused by Haemophilus influenza. What do you do with that? You leave that airway alone, okay? You have them calm. If they don't want to sit in the bed or on the stretcher, doesn't matter. Let them sit in the mother in the chair, calm, because that's the only way they'll breathe. The more they get upset, they're getting restless and more anxious. The child will end up probably with a trach or being intubated. Be careful with that one. Bronchiolitis is another word for RSV, respiratory syncytial virus. We know that these children are isolated. Hand washing is what we need to do. And again, respiratory observation. So if they can't breathe, we're giving IV fluids. And times these children, depending, they might get an antiviral given to them. Mostly ribosol is one of the things, but usually we don't treat it. Now, what we do treat to prevent a child from getting RSV is we're going to give an immunization, and it's once a month. It's for only the first year of life, and it's usually about winter to early spring, so 6 to 8 months, depending. And it's called palivizumab or Synagist, and that will prevent, just say, your cystic fibrosis child, your congenital heart child, the premature infant that has respiratory problems, right? So this is something that can prevent it. And remember, anything airway, airway, airway. Always think airway is your priority here, okay? So respiratory disorders are usually why parents seek medical care. We know that our job is to know what is normal and what's not. Remember, an infant, neonate, first month of life, heart rate 140 to 160, respiratory rate 40 to 60 is normal. But a 1-year-old with a respiratory rate of 60 and 160 is not normal. So again, always go over those values. Ear infections is infection of the middle ear. It is always treated with antibiotics, and it can have a fever. Some are higher than others. Some are not. I mean, I get ear infections all the time. I don't get fevers, but usually children will have a little fever, and it's the pain. It's going crazy, right? You're pulling it, or the little infant is banging their head because their ear hurts. They say put a little bit of heat on it, maybe a warm pack, warm compress there. And again, medicate for pain is a big thing, and administer all the antibiotics. Tonsillitis, viral, bacterial, and then there's strep throats, right? Remember, strep throats causes two different things. It causes acute glomerulonephritis, your kidneys stop working, and rheumatic heart disease, which has a lot of outward signs, rash and nodules on joints. But the heart diseases, it affects the mitral valve and can cause permanent heart valve damage. So one of the things with children before they go to surgery or a tonsillectomy, be concerned about bleeding times, especially if there's a history in the family. If the family says they have a history of factor V Leiden, which is actually what I have, or something to do with clotting disorders, making sure that we do check. Why do we check DTPTT? Because if they're prolonged, they're going to bleed postoperatively, whether a tonsillectomy or an appendectomy. Home care. We're going to give warm saline gargles, ice chips, and antibiotics and fever with the acetaminophen. We don't give ibuprofen because it can cause bleeding if it's given consistently. So, what would you see if a child who's had a tonsillectomy is bleeding and it's classic? You'll look at them and they'll be asleep and they'll be swallowing and swallowing. And remember, what is a tonsillectomy? They cut the tonsils and adenoids out usually, and they cauterize that area. And that area forms a clot, like a scab over it, okay? And sometimes can lift a piece of that clot off or that scab, and they can bleed a lot. So frequent swallowing is a big thing. And then, of course, if they vomit fresh blood, you know they're bleeding. These children, if they're home, should be told to get to the ER. They need to go get OR and get their tonsils cauterized in the OR. I've seen a child, clots this big, go into hemovolemic shock 7 days post tonsillectomy. So it does happen. And I had to literally pick her up myself, run her into the trauma room, get an IV started, pour fluid in her, and she was fine. But it took quick reactions. So respiratory distress, I'm not going to go over all of them. I just went over everything here, okay? That is your test. This is the slide you go back and you look at. So congenital heart. Congenital heart means you're born with a heart that's not, quote, a normal heart. So we have two types. One, that there's a hole in the heart, but all the blood is oxygenated. It's not a problem. And then we have the cyanotic one, where blood's not getting oxygenated and it's not getting where it needs to go. So it's cyanotic. Now, what is polycythemia? Well, think about a cyanotic heart. They don't have oxygen, right? And the body says, you know, there's no oxygen here. What can I do to help get oxygen to the body? Well, where does oxygen travel around the body? In red blood cells. So the body starts producing a lot of red blood cells. There's still no oxygen, but the body says, well, let me try some more, and makes all these red blood cells. Polycythemia is when your hemoglobin and hematocrit are 18 and 54, 17 and 51, and they're so high. A normal hemoglobin hematocrit, 12 and 36, right? That's normal. So polycythemia is extremely common because that body's trying to protect itself by finding a way to get oxygen to the body. We know we're going to do an EKG on any cardiac child, and we're going to do an echo to look at where that blood is going and try to figure out, is there a defect? And then they're going to go for cardiac cath. Signs and symptoms of cardiac problem. Well, problem with the heart rate, heart sounds, murmurs, pulses, cyanosis. And the one that is the silent one is usually they're already been home and they come back with poor feeding, poor weight gain, failure to thrive. It's because they tire out. They're going into congestive failure. And that is when you start seeing those symptoms. Sometimes it's the regurgitation, that frequent infections, respiratory infections, usually is a little bit of failure going on that. And of course, they don't tolerate any activity at all, including just even feeding, right? And then if there's been any history of maternal infection. So what are normal heart rates? Again, go back, look at them. Remember, heart rates start high, 140 to 160, and they go lower as they get older. It could be about 100 by age 1. And as they get older, and now we're the adults, 60 to 100, right? So that number goes down. Heart rates, blood pressures go up. They start 60 over 40, and go to the normal adult 120/80. So just think it goes up. So just look at those things. And when does a heart rate on a child get more elevated? I'm going to go even more than this. When they're crying, absolutely. If they're dehydrated, if they're in pain, and if they have a fever. So congenital heart disease, try to maintain nutritional status. We're going to increase the calories in the formula or the breast milk, and we're going to give smaller, more frequent feedings to give them that little bit of time to nurse or feed and then rest, okay? Sometimes children, they're so overwhelmed, they're so depleted, they're going to need an NG tube and give tube feedings. Remember, they still need that oral satisfaction. Make sure they get that pacifier. Years ago, they didn't believe in it. Again, they believe in it, that they do need it. Heart failure, what do you see? Well, the heart can't beat the way it should. It's tired, or there's obstruction, and it can't beat something, right? So, heart's going to keep trying. It's going to beat faster. Your lungs are going to try to breathe quicker. And then you have no tolerance for any activity, difficulty feeding. And of course, they're going to be cyanotic because of all the congestion in their lungs, grunting, wheezing, pulmonary congestion. And one of the big telltale signs is an increase in their weight. And it's usually quite significant between one day and the next. You'll see it go up quite a bit. And then sweating. Babies don't usually sweat. If they're in failure, you'll see them sweat. And how would you know if they had hepatomegaly? Well, that's your liver, right? Underneath the right rib, if you feel like a very flat area sticking out, that's the liver sticking down. That means it's a big liver. There's congestion going on. You don't feel a liver unless it's swollen. You have to go up underneath the rib cage to find it. And on infants, it's easy to feel, right? Underneath that right side of the rib cage, you feel like a little flat area, and then it falls off. That's the liver. That's hepatomegaly. Nursing plans for intervention, we've gone over this. We're going to do cluster care. We're going to do oxygen if they need, have them sit small, frequent, high calorie per ounce of foods of whatever they need, right? And we're going to be watching them closely, intake, output. They might need diuretics. They might need some digoxin. So daily weights, intake, output, big, big, big. Watching that fluid balance. And again, VOD feeding if they need it. So one of the things about hospitals, and one of the things about weighing them, sometimes there's 3 or 4 baby scales. And you know, my scale at home weighs me 10 pounds less than the doctor's office. Well, that happens in hospitals too, where one scale might weigh more or less than the other. Well, we've learned as nurses, we label them 1, 2, 3, or 4. And we would weigh them on number 1 or weigh them on number 3. And we would always weigh them on that scale. So, and then that gives you a good comparison from maybe morning to night. You want to watch it, depending on what the doctor wants. Rheumatic fever, I said it's that strep infection. And what do? We're going to give that penicillin. And we're also going to give a little bit of aspirin. It's also because of the heart valve damage. We want the blood to be move around a lot easier. And that anticoagulant, aspirin, thins the blood, right? So this is one time that we might use it. This is the other time we use it, Kawasaki disease. Kawasaki is usually young children under the ages of 5. And it's a high fever. They're sick. They have a rash. They've got a strawberry tongue. Their tongue looks like a strawberry. That's what it looks like. Their eyes are so red, they probably could glow in the dark. I mean, they're redder than red. And then you'll see swollen hands, feet. They're irritable. And it's hard actually to diagnose this. The concern is not that it's a viral disease. Our concern is that it affects the vascular. That means your vessels get inflamed and they're worried about the coronary artery. And that causes blood clots and could occlude and cause a myocardial infarction on a young child. So what do? Well, aspirin, absolutely. That's number one. That's going to thin the blood. It's going to stop those clots. And then we're going to boost that child's immune system because it's viral with IVIG, okay? And then whatever we need to do to make this kid comfortable, whether it's lotions, cool compresses, if their tongue bothers them, mouth care, and of course, keeping their fluids. Cardiovascular disorders, know what a shunt is. Know that most blood shunts left to right when we talk about in the heart, because right side is a little pressure. You got the end of a heartbeat, it just gets there. And the left side has all that blood coming down from the pulmonary veins. And actually, there's four. I never knew that. There's four that are pushing all of that. So you got big flow on the left side. So it will go across. So what's our objective in treating heart failure? Well, we want to keep them with nutrition and we want them to breathe easier and want the heart to beat more effectively, right? Now, ditch toxicity. What's the signs? Same as adults, right? What if you're an infant? Can they tell you they're seeing yellow spots? Are they nauseous? But what can they do? They can be vomiting. That might be what you see, and a slightly lower heart rate. That might be all you see. It is better to hold a dose, take a digoxin level, and then know it's okay to feed the child their digoxin, okay? And we know the medication's rheumatic fever. We're going to give them penicillin. Downs. Down syndrome, remember, there's a bunch of different things that can happen with these poor children. The Downs children, I think, are the sweetest. I worked with them as a teenager when I was in high school. I'll never forget some great moments. Taught them how to swim, actually. And then I went to their facility where they had more in-house children, and I would just go play with them. I just thought it was a lot of fun. Anyway, what are they susceptible to? They're susceptible to cardiac defects, many different types. Respiratory infections because of their nose, it holds mucus and it drips down and causes that. Because of their tongue, feeding problems, they will be cognitively delayed. And developmentally, they will be slow. And remember, skeletal defects, they have the weird fingers and toes and creamy and greases and all those things. But these children are the most lovable children I've ever met. Risk factors, low birth weight, maternal infection, cerebral palsy. Also, hypoxic episodes, especially at birth, is where I've seen cerebral palsy happen, and that's part of that low birth weight. What is cerebral palsy? Cognitively, there's an impairment from mild to moderate to severe, okay? They can have seizures and they can have a failure to thrive. One of the things about cerebral palsy, their muscles coordination doesn't work the way it should. So these children usually need help in feeding. Remember, they should be sitting up. Sometimes you have to hold their jaw, whether even just sucking on a bottle to help them manipulate their muscles and make them move the way that they should, okay? You can feed them, burp them, but again, taking your time to prevent aspiration. Spina bifida. This is the myelomeningocele. This is where something goes on with the brain and the spinal column and the meninges. And there's fluid doesn't move all the way it should, right? So what were we going to see with these children? Well, there's going to be usually with this myelomeningocele, think about the nerves get ripped up, meninges get pulled out the spinal column in the lower extremity, the low spine. So the lower extremities, the nerves have been pulled and tugged on. So you're going to have problems with stooling, going to have problems with a neurogenic bladder also. These things to be watched. Sometimes because of a lack of feeling, congenital dislocated hips, club feet, all of this stuff. And we always, with these children, before they even have an allergy, are going to put them on a latex allergy. I mean, today we don't worry about it as much. There's not much latex stuff out there anymore. I have a latex allergy because of the amount of children I used to treat in the 80s when HIV came out and all the scare and everybody wear gloves. And I was in the newborn intensive care unit. And my hands would go into these latex gloves after scrubbing everything every time I walked out of the unit, put the gloves on, and I went into these 110-degree isolates, and it cooked my hands in latex. So I now have a latex allergy from it. So these children with Foley calf, intermittents, multiple surgeries, at first they just say, forget it, everybody. We know that one of the things that pharmacology teaches you, if we start folic acid 1 month, 2 months, 3 months before pregnancy, there's all different things. Some books say 1 month, your book says 3 months. Now, hydrocephalus can happen because of a myelomeningocele. Something about the flow is not working. So it is swelling, right? So what is our big thing? What do you see with increased intracranial pressure? Well, you're going to see an increased pulse, a decreased blood pressure. You're going to know that intracranial pressure is increased because of that decreased pulse and increased blood pressure, right? So shock is going to be the opposite way, but increased in, and what do? What are we going to do for this poor child with hydrocephalus? Well, we're going to put in what we call a ventricular peritoneal shunt. It's a tube that surgically goes, it's behind the ear, you see it. And this tube goes into the ventricle. And there's a little pump station behind the ear that you can actually squeeze, but we don't touch that, only neurosurgeons. And then that tube comes be front of the body down into the peritoneum, and it just keeps that water flowing, that spinal fluid, so we don't have that big increase into cranial pressure there. Okay? Again, don't pump it, and we know better. Measure circumference when we go in every shift. Seizures, tonic-clonic. That's your grand mal. Everything's going all at once. Tonic is just a generalized. Absence is that I'm staring at you, but I don't know you're there. Or it could be like a little twitch somewhere, okay? Myoclonic, sudden brief contracture. This one has no of that postictal. We know tonic-clonic, postictal, they're going to lose consciousness. Many times be incontinent of urine and stool also, okay? We know that a lot of times in seizure in children, it's not necessarily medical noncompliance. Is children gain weight and get big quick, and we don't increase the doses as quick as we should. As nurses, this is something we can monitor. Say we know that they should have 2 to 4 milligrams per kilogram of this dose of this medicine, and this child now weighs this, they should have a bigger dose. It's something we could say to the doctor, please look at that. And again, any seizure, don't stick anything in the mouth, turn them to the side, protect them, safety, and have suction at the bedside if we need to suction the vomit around them, never in the mouth. Bacterial meningitis. This is dangerous. And this is something that if we're suspecting it, these children need to be put in isolation immediately. Immediately, you put a mask on, an N95. Put that child a mask on, getting them into a room. And these children will be on droplet isolation for 24 hours. They will start the antibiotics, and then 24 hours later, they can be off of the isolation, okay? What's the big deal with meningitis? Well, these children are almost like having a migraine. They're sensitive to light and to noises. So keep it quiet, keep it darkened in the room. And you always, anything with the brain, worry about seizures. Make sure we measure intake output. We don't want too much incoming and not enough coming out because we don't want fluid overload. It's going to create more pain in there. Again, infants, we're going to be measuring their head just to be sure. And guess what? You have the Hib vaccine, protects against H influenza infection. I think that was a question that I heard last week from one of y'all. So again, monitor hydration. We know that's really important. We know that sometimes there is that inappropriate antidiuretic hormone, and that's in that pituitary gland. And sometimes it stops fluid from coming out. So again, hydration, intake, output, daily weights, really important in these children. Ray's syndrome caused by influenza, viral disease, usually before and then aspirin is usually when we see it. Brain tumors, how do we know? Well, brain tumors, couple key things. Headaches that wake them up at night. Usually headaches don't wake people up. All right. Vomiting has nothing to do with when you ate. And it's not that you're just nauseous and vomited. You wake up and just start vomiting. You can't concentrate. You're not behaving right. Sometimes you can't see correctly. Now, in infants, that fontanelle might be separating. We might see that. Or if it's getting that bigger, we might see gait. They're not walking right. They're falling over. Stuff like that. That tumor's occupying space and it's not letting the brain do what it's supposed to do, okay? Remember, post-op on any child that's had a brain tumor, always find out what side you can turn them on. Sometimes you can't. Very important. This says that a large tumor may require that the child not be turned to the operative side. Sometimes they want it on the other side. Can't always find out. I would never turn a child unless I read the doctor's order on what they wanted. So again, anything fluid, brain, pressure, head, intake, output, right? Careful of overhydration. Muscular dystrophy. 1 second. I am sorry. So muscular dystrophy. Well, what this is one of those progressive atrophy or decreasing function of muscles. One of the biggest ones that we will see, and you'll be tested on, is Duchenne muscular dystrophy. So this child is cognitively delayed a little bit, but has been up walking. We're going to be seeing big hypertrophic muscles in the calves usually. And all of a sudden about 2, they start going backwards. They start waddling. They start their back arches, that lordosis, lumbar curve inwards with like a point backwards. And these children are falling down. You'll also see them get up like me as an old lady does, walking up my legs to stand up. That's Gower sign. And kids don't do that. They usually stand right up, right? So it's a progressive muscle degeneration, which ends up with the respiratory diaphragm stops, heart stops. They end up in wheelchairs before that, and that's muscular dystrophy. So again, all of these things, what else here that we didn't go over? Side effects of phenytoin. The other name for phenytoin, this is a pharmacology question, Dilantin. Side effects, acne, hirsutism, hair, and gingival hyperplasia. You will see young children with CP on phenytoin, and you know they're on it because you see acne and you go to change a diaper and there's pubic hair. And you go, okay, and they're 6 years old. Very common on phenytoin. I hope that makes you remember that. Acute glomerulonephritis caused by strep, right? So what do you see? Well, the kidney stop. And what is that? You start, you'll see them stop urinating. You're going to see them getting swollen up, especially facial and around the circumoral, around the eyes. You'll see that. And you'll see their urine turn dark, bloody, and with protein in it. And it's due to a strep infection. What do? Well, we're going to start giving them the antibiotics and we're going to turn it around, but we need to treat those symptoms. So a kidney patient, what do? We're having problems not urinating. Intake, output, daily weights, always. Monitor fluids, right? Low sodium, all of that. And then if they need it, let's give them something for a high blood pressure. And we know if that sodium gets too high in there, seizures can occur. So always watch out for those things. HESI hint, urinary output, you see it decrease, first sign of renal failure. Absolutely. And that's why dehydration, we're going to see decreased urine output. I'm saying it's the worst thing we can do for a child is to leave them in dehydration, is because they'll go into kidney failure. Now, nephrotic syndrome, I'm going to say it twice, has nothing to do with kidney failure. This has nothing to do with kidney failure. The kidneys work, but you know what the kidneys say? Oh, protein, I don't like you. I'm going to get rid of you, and gets rid of all the protein out of the body. Well, that's a problem. All right. It's going to cause a lot of fluid to go interstitially. So you swell up everywhere. Your tongue even gets swollen. So you don't want to eat because it hurts and you keep fighting it. So edema, it gets worse. You're going to see them get pale, tired, no energy. You're going to have almost looking like beer for urine coming out. Massive, massive protein in there. And if you were to measure the protein in the blood, which is also called albumin, it's very, very, very low. Okay. And they actually causes the lipids to go elevated. So nephrotic syndrome, what did I tell you? Intake, output, daily weights, diet, fluid restriction. We're going to be monitoring these children for infections. They are immunosuppressed at this point, and treatment is steroids. This is nothing that's going to be cured. It is something that these children have to live with, okay? And at acute phases where they blow up and are swollen, they'll get steroids. UTI, most common of all of the urine problems, right? A lot of times they come in, they have a fever and they vomited once, believe it or not. And they do a urine and it's a urinary tract infection. Now, sometimes if we could smell the urine, I mean, that would be easy, but it's very vague. It really is. It just takes that keen practitioner to look at it and go, oh, let's do a urine to be sure. Now, older kids, you're going to see that frequency, that urgency. They're going to be holding themselves. And then, you're going to see the smell in the toilet. You're going to smell those sort of, after they go to a bathroom. Urinary tract infections, number one, get a good specimen. We want to treat it the first time and treat it with the proper antibiotic. That's why infants, we do catheterize. There's no immune system. We want it the first time. We don't want 3 different antibiotics to have to take this poor little child, because antibiotics have their side effects too, right? Nausea, vomiting, diarrhea. We don't want that. So you get your specimen and make sure they finish all their antibiotics. Now, what can we do to prevent them? Well, number one, fluids. Full juice. not just only cranberry juice. I've always heard cranberry, right? Well, put apple in there also. And little girls should avoid those bubble baths. And again, teach them how to go front to back and not to hold it. They need to go to the bathroom, make them go. Now, Wilms tumor is a nephroblastoma, a kidney tumor. I've seen one in my career. And this was a little boy who came from Haiti after the Haitian earthquake many years ago. That's how long ago it was, and only one. And I was doing an examination because I didn't speak French. I couldn't read the orders that came over, and the people who brought them to me were just a religious group that did it to get the kid over here for treatment. And I felt the left lower quadrant, and I felt this big of some mass. And I don't know why I knew it was a nephroblastoma or a Wilms tumor. Big, big thing. These tumors, once I felt it and I had a suspicion, on the chart, do not palpate abdomen. Leave it alone because it's fragile. It'll break and it'll metastasize. They don't even do any sort of biopsy on this. Oh no, because it'll leave a little hole in it to make the metastasis to go all in the peritoneal cavity. We don't want that. Hypo or epispadias is when the urine doesn't come out the end of the penis on a male. Hypospadias, it comes somewhere underneath. Epispadias is somewhere on top. And the big thing about this is to get them fixed, keep the foreskin there. They can't be circumcised. They need that for the plastic closure. And to get it done before we feel like we're castrating them or they have a problem, as in if we get it done before they're potty trained, it's the best thing possible, okay? So that is the big deal with infants, toddlers, preschoolers, correcting it. Try to get it done as soon as we can. Renal failure, what happens? Well, what causes renal failure? Look what number one is. How many times have I said? Dehydration causes renal failure. Again, trauma to the kidneys. I've had kids run, turn around, hide and seek, out playing in the yard, banged against a trailer hitch. Back of his came to me. He had ran into that hitch, big ecchymotic area. He'd fractured his kidney, but he was okay in the end. But big bruise, a lot of pain, fractured kidney. So another thing that can cause it is obstructions. There's all sorts of in the ureters or hydronephrosis. All of those things can cause it. Congenital and sometimes infection. There's also medication, some of them. So any of these right there, we got all of those there. GI disorders, cleft lip, cleft palate. We know that the problem with that is feeding your child, right? Cleft lip, they can't close it, they can't suck. A lot of problems with this extra suck, even with the hole in the palate, is all of this milk, whether it's breast, whether it's formula, it's going up, it's going into the ears, causing ear infections. All of these things can cause hearing loss. If they don't fix it, with the palate, which should be about 12 months, the lip about 2 to 3 months, they don't get it done, they're not going to speak anytime like this because they can't make that good seal. So again, that can lead to a lot of things. And as the kid gets older, it's not repaired. How about those kids teasing them about a child, the way that they talk? Maybe they got the lip repaired, but the palate wasn't done yet. So remember these things. Another thing is these kids, when they're born, they don't look pretty. And it's hard for a mother to look at that child. So I know as a nurse, I've seen many of them. I would say, oh my goodness, look at the hair on that kid's head. I can't wait to comb that hair. Or, oh my goodness, big feet. Take the focus away from this. We're going to fix that. And that's what you do. And then show them the picture of a before and after and say how beautiful they can look. That's what they need to focus on, not that's fixable. Now, what about esophageal atresia tracheoesophageal fistula. This is all about food, mucus being swallowed, and it has nowhere to go. The esophagus has no stomach attached to it. It has sometimes attached a fistula, a tube, between the esophagus and the trachea. Guess where that mucus that I'm swallowing, this little baby says? Well, it goes right into the lungs. And what happens? They get aspiration pneumonias because of their own mucus. So, what is the thing here? These children always, this is all respiratory, that mucus, keeping it clear, that mucus is going into lungs. So we know we're going to have some respiratory compromise. Suction, absolutely there. Sometimes it's constant, sometimes it's not. All depends on, what they've done, if they need oxygen. But big thing. Nothing by mouth. Don't put little water in there because you think their tongue needs water, because they're going to swallow it right into their lungs, okay? And this is at birth, this happens, all right? Give them that self-soother, give them a pacifier. They can't eat. Let them feel that comfort. They're going to get nutrition with IVs, hyperal, all of that stuff, but give them that comfort. Pyloric stenosis, somewhere between 2 weeks, 3 months. All of a sudden, the pyloric sphincter in the stomach gets thickened, muscular, and tiny, and no milk can go down into the intestines. And the stomach goes, woo, and it stretches out. And all of a sudden, no pre-warning, they're going to vomit across the room, called projectile. You can literally have a garbage can 10 feet away, point the infant, this little 2-month-old infant, 10 feet away, garbage can, point it at it, and they will projectile vomit into that garbage can. That's how forceful. I wanted to make sure that you understood that. So these children, they are hungry, they want to eat, they're not getting any nutrition. What would I do? Now, many children, infants come in, mom and dad say, well, baby's vomiting. My question, do they dribble or are they across the room? And if they say out, immediately I take my hand, I put it underneath their xiphoid process, and right around that area, you'll feel an olive. I call it a marble. Same thing, a hard and round something. NPO from that point on. What are we going to do? We'll do an ultrasound. We'll start an IV to give them fluids, and we'll get them up to the OR. Once they're done with OR, they stretch out, make that sphincter open. They're going to be given some sort of oral feedings slowly. And these kids go home and they usually nothing since. They do really well. Intussusception. Seen many of these too, with many different outcomes. It's when the intestines, for some reason, sucks into each other. And then what happens? It swells and it can't get out because it swelled up and holds it in there tight. So that intestine is now dying. This kid is screaming in pain. Legs, arms going. These are young kids usually. Youngest I've ever seen is 5 months, and up 3-4 years old is about the areas I see. So kid comes in, see this kid, arms and legs going, ask mom what's going on. All of a sudden, he started screaming, and then he stopped, thought we were going to cave, and he started again. Intussusception. I'll take my hand and feel that belly. It's tense. That's first clue. Second clue, I look in the diaper or into the underwear, and I see this jelly. It's called currant jelly. It's clear with streaks of blood and mucus. That's what it looks like. And you're like, there we go. You also will see a sausage-shaped mass in the upper right quadrant, okay? So these are the things. How do we treat it? Well, many of these kids, they'll go to ultrasound and it's already gone. I think one kid I've ever seen go to the OR that had to take intestines out Usually it will come back by itself, or we do other things in radiology, which will pop it out. And then we put them on a higher fiber diet to hold it open to keep it going. So that's the end. Nutritional needs, fluid and electrolyte balance are key for any child with GI bleeds, for sure. Just think about all of the nutrition you're losing every time you have a little bit of spit up, like with reflux, right? So again, sometimes we need to increase the calories. Sometimes we need to pay more attention, slower, more frequent, less volume feeds, whatever it takes. Now, Hirschsprung's. This is when that descending colon, so that your intestines, has no nerves. So you have the tube, it's there, but it doesn't squeeze and have paralysis, and it doesn't function. And it just gets bigger and bigger with whether they're eating, whether just normal mucus, and it gets bigger and bigger. And usually you're not going to see any stooling on these children at all. These children, if we are seeing that they're not stooling, or maybe this tiny little ribbon stool might come out. We know it's a megacolon. It is an obstruction. Something's going on there. Always a nothing per rectum. And what we do is we will take these children to the OR. That piece of intestine does not work. It's never going to work. So it needs to be cut out. And they take the good end, try to attach it to the very end by the rectum. We want to do it that one. But sometimes they end up with just a colostomy. And then usually before one, they will have it closed before potty training again, right? Remember it, big thing, making sure we're not messing with their brains on their private parts where we think that, they are, being mutilated, right? This is what the way the kids think. Appendix, we know that we have the ones that can rupture. We also know that what we see in appendicitis, right lower quadrant, pain McBurney point, then all of a sudden the pain stops and we know it's ruptured, right? What are we going to see? All of that debris is in the peritoneum, creating peritonitis and still needs surgery. Celiac disease, nutritional. It is the small bowel has this villus atrophy. Those little things that like to suck up nutrition and give it to the body does not like gluten. And when gluten's there, it goes bonkers, creates a lot of pain on these children, okay? Now, you need to know what gluten is. Wheat, rye, barley, oats. What do kids like to eat? Macaroni and cheese and breaded chicken nuggets, right? Bread, 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 bread. No, they can have dairy and chocolate and fruits and vegetables and all of that. They can't have bread. Although today, they don't know how lucky they are. Even at the local grocery market, gluten-free is everywhere, isn't it? If you look for it, they have gluten-free bread. Rice is the rice flour that they're using for it, and it's working very well. Well, what would you see with celiac disease? Again, these kids are not tolerating fat. So there's something called steatorrhea, which is foamy, fatty. It's gone right through the intestines, and it stinks horrifically. It's the most foul-smelling stools that you will see. Because of the fat, what does fat cause you? Distension and cramping, and diarrhea, and then they don't feel like eating. And because they're not getting all their nutrition, they're not going to be grown on that chart the way that they should, right? How do we take care of them? Gluten-free diet and educating, letting them know what's going on. Gastroenteritis, very similar to diarrhea here. Same thing. Inflammation of the stomach, intestines. Still, diarrhea is gastroenteritis, whatever you want to say. So again, making sure they don't get dehydrated, oral or intravenous fluids is what we need. monitoring the intake and output. And you and me, remember, hand washing, hand washing, hand washing, and teaching the mothers and fathers too. Gastroenteritis. Once we start reintroducing fluids, never to do these high sugar things, the sugary, the soda, the fruit juices. No, they should be on the Pedialyte, Powerade, Gatorade, and even half strength on the Powerade, Gatorade. Okay. And no, we're not going to give kaopectate. Pepto-Bismol should not be given to children. Here's all your GI stuff. Let me see if I've done all of these things. The barium enema is used to treat an intussusception because it pushes out the intestines. It is done by the radiologist under fluoroscopy to push out that resistant intussusception. That's what that's for. Right. Iron deficient anemia. Let's go into blood stuff now. Well, the first group, those two groups, I told you, high risk for it. Toddlers, right? They don't eat good. What else? Adolescents. They don't like to eat that well either. So those are your two big groups. So what is the cause? They don't have enough iron. They don't eat right, or they're losing a lot of blood. Could be the adolescent, with big periods, right? Losing blood and all the iron out of them. Also, sometimes we know what happens with iron deficient anemia. If we're always on a low hemoglobin hematocrit, the heart has to make up for that, get the oxygen and iron around nutrition to the body. And it's going to try, and it's going to end up failing. And that's why there's cardiac issues. And because they're not getting the nutrition, again, failure to thrive. Their growth, their height, weight, not going to be on the scale. These are the numbers that they say. So what do we do? When you don't have iron, you don't have oxygen, you don't have iron in your body, and you're tired. That's the big thing. My kid's just tired all the time. I don't know. They were fine. Oh, and they're just so tired. Well, that's the biggest clue of iron deficient anemia. So what we need to do is to tell them to eat things high in iron. And these things, you'll always see these types of things on HESI. Meat, green leafy vegetables, fish, liver, whole grains, legumes, iron fortified cereals and formula. And that's why the first 6 months they never have iron deficient anemia, because they're getting all the iron that they need. Hemophilia is when you bleed. And you bleed because all of the things you need to stop bleeding aren't there, called factors, right? They're just not all where they should be. What is the initial thing that you would see besides bleeding, whether overtly bleeding or a bruising into a joint that keeps bleeding and getting bigger? Well, first thing we're going to see is an elevated PTT. That measures heparin, right? But it also measures how thin your blood is and how much bleeding that's going on. So as nurses, you need to protect the joints because they can get irritated, destroy them, and these children will end up crippled. And we don't want that. Okay. Remember that we're going to be given factor. Sometimes they do it at home. Sometimes we do it in the hospital. Preventing bleeding, soft toothbrushes, soft stuff around the house. Then these children don't have cell phones yet with their medical care. So somewhere letting them know this child is a hemophiliac, a necklace, a bracelet, something. Let me know what's going on. Sickle cell, when the cells are not born in the normal shape, they're born sickles, they die quickly, and they get clogged up because they can't get down all of the blood vessels. That's basically it. The key to preventing sickle cell disease are these sickle cell crises. Keep those veins big. Let's let those cells get down there. So hydration, hydration. And if you're in cold weather, keep warm, right? And sickle cell has nothing to do with iron, okay? That's a misnomer. So iron's not going to do anything. Sometimes they'll give folic acid. That's only to keep the red blood cells there, but the red blood cells that they have. So Remember, hydration opens up the vessels, puts the clogged ones through, and that will help them decrease the pain. ALL, this is acute lymphocytic leukemia, and it's cancer. Gets to the white blood cell and says, yum, 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 I like you. And now you have absolutely no white blood cells. Well, what does that mean? I don't have an immune system. I don't have any white blood cells. So we need to get this body producing good cells to take care of itself. So we're going to be doing chemotherapy. They do 4 phases. The induction is actually, they hit them 2 or 3, whatever amount of chemotherapy agents for 4 to 6 weeks, and the goal is remission. But they keep going onwards to make sure there's no cancer cells hidden anywhere. Okay. One of the things about the chemotherapy agents that we give, they can have allergic reactions to. So that's what this is telling you. Have epi there and oxygen in case of an allergic reaction. Also, they do give a lot of prednisone with these, again, to try to reduce what's going on in there, all right? And remember, allopurinol, we use that for gout, if you remember that from pharmacology. We actually do that to prevent any problems with their kidneys, uric acid, gout, and that's, further down the line. So let's see what else we have here. All right. Congenital hypothyroidism. Well, what did I tell you about thyroid? You don't have enough thyroid, you're not going to grow. And cognitively, you're going to be behind. So these children, if they're not getting enough thyroid, they're not going to be, as I said, turning over by 6 months. They're not going to be sitting unsupported by 8 months, lifting their head by 3, 4 months. And then there's a problem. What they do is they're going to be doing a diagnostics, which they're going to be looking at the thyroid hormones. There is T4, TSH, there's also T3. Remember, if there's low T4, there's high TSH, and that's across the board, okay? One of the things about hypothyroidism is these children are lethargic or not as active, just like you as an adult. Hypothyroidism, you don't have that energy. It's what everyone says. Well, an infant who's that quiet baby could be hypothyroid. So it's something to look for. So they're hyperactive. Also, children with thyroid problems will not have their first bowel movement after birth for 24 to 36 hours. And it's one of the things I'll be checking for. Well, one's Hirschsprung's disease, and one is hypothyroidism. The other is cystic fibrosis. Those 3 things is we're like, something's not right. Let's test for it. Then you're going to see them not doing things like pour suck. They just can't take care of themselves as in maintaining any temperature. You're going to see them as they get older then with the protruding tongue. You'll see coarse hair, constipation always with it. And because they're not cognitively where they need to be, you're going to see hypotonia. So we're giving them their thyroid hormone, very important. Now, conversely, with hypothyroidism, remember, we're going to be given Synthroid, or some sort of thyroid medicine. Remember, parents can forget they gave it, or the kid gave it to themselves, and the parent gave it, and they have double doses. Now they're overdosed. Remember, that's the same as hyperthyroidism. And what is that? Elevated heart rate, just irritable, just, you'll see the child very anxious. That could be that they have an extra dose of medicine. And again, they should go to the doctor to be checked. They might need more than just watching, okay? And then, of course, the underdose is not only that cognitively they're not where they should be, but they're still tired, they're still fatigued, okay? Still constipated. And we know anybody on thyroid medicine is going to get periodic checking. Now, PKU is a type of nutritional problem, and that's the little circles that we do at birth. And it does prevent things like central nervous system damage, cognitive impairment, and then it also it's not going to have that decreased melena, which means you're going to have, you know, the darker skin, the darker hair instead of the lighter side. We treat this basically with diet, seriously. So diet's the most important thing. There's formula. Sometimes it's hard to get for these children. And then again, as we introduce foods, vegetables, fruits, juices, cereal, bread, starches are also a good thing. They say also, as a kid gets older, and it's not used as much anymore, but Nutrici, aspartame should not be used in any child with PKU. Now, diabetes. Diabetes are 3 Ps. I'm hungry, I'm thirsty, and I urinate a lot. And I'm hungry because my body's not using any of the sugar and it's just sitting there. So, children diagnosed with diabetes are diagnosed as type 1, okay? But they do have some older children that are type 2, okay? It's not the young kids. Young kids are type 1. They're always type 1. They're not going to change, okay? So, and a lot of the reasons why they're saying you have children with type 2 now is because you have these sedentary lifestyles and you have children that are overweight. And those are 2 big things, even in adults. Overweight, sedentary, you're more apt to get diabetes. Same thing. So congenital hypothyroidism, you're going to see those cognitive delays. I showed you the formulas, 3 signs. Hypoglycemia, hyperglycemia. Well, hypoglycemia, this is a child that can go unconscious on you, right? They're going to be jittery and sweaty and nervous. And hyperglycemia, it could be to the point of DKA, and you could get that pale, diaphoretic, dizzy weakness on it. And you can sometimes even smell the sugar coming off of them. So fractures. We have different sort of fractures. We know that minutid is bone fragments. We know open is the one where the bone comes out, where that child's going to need antibiotics for that because it's come through the skin and now get infected. Our biggest concern is that they hit the growth plate, which is right at the end of the bone. And if we don't do surgery and do an open reduction internal fixation, that bone could be crooked. And guess what? Your arm will be crooked if it's in the elbow. It also could be the leg. You know, if it's not done correctly, it could be shorter one leg than the other. It's very important that we get those growth plates and that they're fixed properly so that the bone can grow the way it should. We know 5 Ps is always that we're looking. We want to make sure that the pain, the pallor, the pulselessness, paresthesia, paralysis, making sure that, you know, the casts aren't too tight on them. Also, if, you know, there's extra swelling going on, the feet are turning pale, that could be compartmental syndrome, you know, and again, that can turn a foot, a leg, a toe black, and you could lose any of those pieces, all right? And then we have traction. We have a type that's skin that pulls, and then we have stuff that are pins. Remember, if it's pulling to keep that leg straight, if it's that buck traction, make sure the weights are free hanging there. If it's splints cast, making sure that we are teaching these parents and these children what to do. pin sites, and this could be in an external fixation device for many reasons. Those pins, they're out in the environment. What is the pin care? Again, it's whatever the physician says. It could be soap and water, antibiotic ointment, or not. Remember skin traction. We never take that off. Bryant's, it could be Bryant's, it could be Bucks. Any of those, leave them alone. Russell's, leave the traction, keep them pointing. Always check neurovascular signs, okay? And again, kids don't like shots, right? Don't tell them it's a shot. Hip dysplasia. Bones are not born inside the socket. They're up here somewhere. So you're going to have the doctor, a pediatrician, first visit. They take their knees up and out and they wiggle them around and they're listening for that clicking. Okay. They're going to look at their buttocks. One's going to be higher than the other. One leg's going to be shorter than the other. And then we put on that Pavlik harness. Usually not the others, but usually it's a Pavlik, and it's going to try to abduct that back into the hip socket to where it should, okay? The thing with this harness that we can take it off for 1 hour today, only to inspect the area, to rub it with lotion, make sure it's not reddened, and then we can put it back on. Scoliosis, S-shaped curvature of the spine. Big thing here is that adolescent, pre-adolescent growth spurt, where they gain 20 to 25% of their height. Right there when they're growing that's when we really see scoliosis. We'll see one shoulder, one hip elevated. They're not aligned, all of this. And if they're bending forward, you'll see that rib coming up there. What they do is they put on a brace, a Milwaukee brace. Again, 23 hours a day. You take it off for bathing. I inspect underneath. It's always a t-shirt or a little cotton something underneath, whether it's a Pavlik harness, scoliosis, there's always something underneath it. And you're always looking for any skin breakdown or anything. And scoliosis, most of the time, can be with extensive physical therapy, strengthen those muscles. Sometimes scoliosis needs surgery. And you've heard of log rolling. Well, this is when it would happen. They do surgery on the spine. And either they do a fusion or they put rods in it and the child is flat on their back. And what they do is you'll log roll something between their legs, and you take two people, turn whole body at a time to change into their bed, to change a bedpan, or whatever they have to do. JRA, JIA, whatever the name is, it's joints being attacked by the body. How do we treat it? Well, they need exercise. They need to get up and keep them moving and keep them stretched. The best medication for pain is NSAIDs, ibuprofen, or any of the others. Then we'll go into the anti-rheumatic. It could be methotrexate, one of them, or they could do the Humira or other. There's so many more, I can't even tell you. I think I've been on 10 already. So there are a lot of them trying to get where you're treated and it's effective. And then for flares, it's going to be your steroid. The one thing about JRA, these children need to have periodic eye exams because the iris can get inflamed. And if we don't get it as we see it, you could lose eyesight in there, okay? And of course, corticosteroids, this says low doses during exacerbations. Whenever you use corticosteroids, always know that there's so many side effects. We use them for the shortest amount of time as we possibly can because we know it does affect growth too. So skeletal orders. Let me see. Yep. Pretty good. And look, we did it, guys. A lot of stuff there. I think I was pretty clear. I think that I explained it in a manner that y'all can retain a little bit of it. I am doing tomorrow a HESI Q&A. I do it's RN and PN. You both study the same thing, but it makes you think things to look for. Again, I will post that for you on your site so that you do have that in case you can't come, but I'll have it there for you. Any questions? So you're ready to go get a 99.99? I would love to see that. I think Elena's ready for that one. I know Courtney wants it. And I think Andrea too. She's pretty there with it. Tiffany's going to surprise me this time, right? 99.99. I'm going to end class tonight. We've done it all. Remember, week 11, no class. Your HESI's your class. Week 12, I'm going to have 2 times for you to see me, whether it's Monday at 3 p.m. Eastern or Wednesday, 6 p.m. Eastern. If you cannot make either of them, send me a message. I'll meet you quickly. When you get that end of term evaluation, please fill it out. It means a lot to me. I want to know what you feel. I want to know what you like, what you don't like, what can I do better? Because I always look at to improve myself for the next group. And that's all I have, guys.
Professor,